Good afternoon, everyone. From us here in Nairobi, Kenya, my name is Natasha Gilani, and I serve as the project manager for the Coalition for Women's Health in Africa and the host for today's webinar. It is truly my pleasure to welcome you all to what promises to be a powerful and timely conversation under the theme Fund the Future, driving domestic investment for women's health amidst global funding shifts. This dialogue could not come at a more critical moment. Due to the recent shift in global health financing, driven by economic turndowns, geopolitical instability, and competing global crises that are threatening to reverse the hard-won gains made in advancing women's health across Africa and beyond. Now more than ever, we must champion innovative, sustainable, and locally driven solutions to safeguard and expand the impact of women's health initiatives. So before we begin the session, I'd like to share a few brief guidelines to ensure a smooth and engaging session. So this session will be recorded for documentation and future reference. By remaining in this session, we kindly request your consent to be a part of this recording. Please keep your microphones muted throughout the session to minimize background noise and to avoid interruptions to the speakers. We highly encourage active participation, so please feel free to share your questions, comments, insights in the chat box at any time during the discussion, and we'll do our best to try and address them during the Q&A segment. So to help navigate this timely and critical discussion, it is my absolute honor to introduce our moderator for today, Mrs. Marlos Kibacha. Marlos is the co-founder and managing director of Africa Health Business, a pan-African consulting firm committed to strengthening health systems in Africa, by Africa, for Africa. With over 15 years of experience in healthcare research and consultancy, she brings deep expertise in strengthening healthcare systems. Marlos has advised some of the largest institutions, companies, and investors within Africa and beyond. So we're truly, truly privileged to have her guide today's conversation with depth, clarity, and purpose. So please join me in welcoming Marlos Kibacha. Over to you, Marlos.
Thank you, Natasha. That's quite a mouthful about me. I'm wearing pink, everybody. This is the COA color. We are advancing women's health also in the dressing that we have today. It's my honor to moderate this session. It's always exciting to me when we talk about women's health, and especially women's health in Africa, where we can progress a lot, where there's a lot to be done, but also already a lot that has been done. So again, I'm very excited to moderate this session and learn from our eminent speakers. Before I move to the agenda of today, I would like to give you a bit of a background about the Coalition of Women's Health in Africa. Some of you might have already joined webinars, roundtables before, or some of you might be members, strategic partners of our coalition, but some of you might also be new. So for those who are new, just a bird's eye view of what the Coalition for Women's Health in Africa is, in other words, COA. COA is a membership-driven organization driven by the private sector to advance women's health in Africa. We are followed by the vision an Africa where women and girls have access to equitable healthcare and optimal well-being. And we do that through catalyzing partnerships, through knowledge, advocacy, and action. And as Natasha already mentioned, I'm the MD and founder of Africa Health Business, and we serve as the secretariat of the coalition. On this slide, you can see the members. So we are a fully private sector driven and paid for organization. Our membership fees make it possible to do the work that we do. And the work that we do is covering or divided in 3 pillars. First pillar is the knowledge and research pillar, in which we generate an evidence base for the decision and the direction or focus that COA has. Second pillar is awareness, policy, and dialogue, where we're basically creating noise, partnerships, and again, dialogue on issues affecting women's health, with the ultimate goal to improve the status of women's health and to move to action so that we can create an enabling environment where women can thrive and their health is quality, accessible, and also affordable. We're quite a young coalition. We were founded in 2020 and started really our work in 2023, guided by a strategic plan that is set up by the 3 founding members at the time. And since the last 2 years, we have shared quite a bit of work in terms of webinars, roundtables, dialogues, but also in terms of knowledge and research. And on the slide, you see some knowledge reports that we have prepared. I really encourage you to go through our website, coa.net, or follow us on LinkedIn to get access to these knowledge sources and to take advantage of it. Since we cannot boil the ocean, and COA is still young with a relatively targeted scope, we can't boil the ocean. We cannot boil the whole of Africa in terms of accessing or creating accessible women's health. So we have focused initially on 3 countries: West Africa, East Africa, and Southern Africa, Ghana, Kenya, and South Africa. But we hope to do a lot more and get more members so we can also expand our reach geographically. But in a nutshell, this is a bit about the Coalition for Women's Health in Africa. And as you now all know, Natasha is the project manager. This is her bread and butter, running this coalition. So feel free to reach out to her in case you want more information about the coalition or just like to have a chat with us and to explore how we can work together. So that in a nutshell about COA. Let's go to the session. Today we are talking about funding the future, driving domestic investment for women's health amidst global funding shifts. As I think we are all aware, the current global geopolitical situation where nations, Western nations mainly, are more focusing on their own security, their internal and their domestic focus areas, and less on the outside, the development funding has been hit. And the African continent as part of that as well, and is one of the mostly affected ones. In this session, we want to understand what has happened, but also to see, well, we're seeing all the need to scale up domestic funding and investments in health, but in particular, since we are COA, we want to focus on COA's health, on women's health. So how do we drive domestic investments for women's health, given the current situation that we are in? And we want to do that through the following agenda. You want to go to the slide? Yes. So we have done the opening, the introductions. I am starting. This is my time now. And then we'll move to our esteemed selection of speakers. Dr. Matiko Riro, Ms. Vuyo Mjekula, Dr. Manjanga Lucy Mazaba, and Dr. Katharin Dirangu. After that, we'll have an open forum where, as Natasha mentioned, we encourage you to make it interactive. So any questions you have that come up during our conversation, please type them in the chat box. Then our team makes sure that they will reach me and I will address the question to the person it's intended for. After open forum, we have some closing remarks from our speakers, some reflections, and they will throw it back to Natasha where she will close the session moving forward. So let's go to the overview of our speakers for this session. This is a visual of what they look like in pictures, but you will see them in moving image in the video. And before I introduce our first speaker, I want to move a bit to a high level, very high level overview of why is it so urgent that we are focusing on this topic right now. Is women's health in Africa at risk? Well, to answer that question, and I think we will discuss that further in this session, we wanted to share a high-level overview in general health financing. Where are we at? If we're looking at health budget, I'm sure you must have heard the Abuja Declaration, where countries have pledged that 15% of their national budgets will go to health. If you look at the focus countries of the coalition, Kenya, Ghana, and South Africa, you see that number has not been reached. Ghana is at about 2.98%, Kenya at 5.28%, and South Africa at 11.5%, way below the 15%. This is not even women's health, it is general health. Only 3 out of 55 African countries have actually met that 15%, and I think it's worth mentioning those countries here because they're doing something right in terms of healthcare allocation. It's Rwanda, Botswana, and Cape Verde. Then if you look at the countries again in Africa, more than 30 do not reach even 10% of the Abuja Declaration. So not even the 15, but don't even reach the 10%. If you look at health expenditure as a percentage of GDP of the COA focus countries, you see that 3.7% is reserved in Ghana, 4.3% in Kenya, and about 8.7% in South Africa. If you look at the health budget, how is that health budget then again divided? These are average numbers in Africa. It's not from one specific country, but on average, you see that about 10 to 15% of the health funding relies on foreign funding. And that is the funding we're also discussing here. That has gone even down more. And about 45% relies on public or government expenditure, and about 35 to 40% of out of pocket. So a lot of families using their own funds directly. And it's often mentioned that out of pocket payments are the direct cause that people go into poverty. So this is also a high number. If you look at the general overview of what is spent in global health, it's about 100 billion. Less than 10% of that is focusing on women's health. And if we dive deeper into women's health, we'll go to the next slide, where we see that women's health is affected by donor funding. Even though it's only 10% allocated to it, it's 10% of that is significant, and that we can see directly in the projections that are coming up for this year. For example, when we're looking at maternal health, Sub-Saharan Africa accounts about 70% of the global maternal deaths. And it's anticipated that this year, 178,000 women will lose their life giving birth or in the process following or before this year. This is 10% more compared to last year, and this can be directly allocated to funding cuts in women's health and in maternal health. Funding cuts are there. However, investing in women's health and in family planning, RMNCH services, research has shown that every dollar you invest will give you $9 in economic benefits. So it's really urgent for African governments to realize this potential and to invest in this, because it will give them quite a good ROI, about 900%. If you look at the situation of cancer, it's also not looking that positive. It's projected to rise to 200,000 cases in Africa by the year 2040 if we don't have urgent action. And if we look at the breast cancer survival rate, it's expected to go down due to screening becoming later, because it's not funded by partners anymore. Women will continue working with issues they might have or not knowing they have issues and not screen on time, which will make late presentation cases, which will not help the survival rates. And that is linked also to a projected increase of about 135,000 deaths by the year 2040. This is not different for cervical cancer, and I'm excited that we have a partner that helps prevent cervical cancer through HPV vaccination in Africa. But given the current situation, if it remains as is with not further investments in women's health and in prevention, cervical cancer deaths are also will increase this year and continuing years to go. Just a very high-level overview, and we will hear a lot more from our experts. Just to quickly go, what will this session achieve? We want to highlight the funding gaps. We know they are there, but what is actually the impact? What have our experts realized and are witnessing right now in terms of funding gaps? But it's always nice to talk about problems, but it's better to talk about the solutions. And innovative domestic financing models or innovative blended financing models are a tool to overcome this. We want to hear from our speakers what are innovative models that they have come across, that they have experienced, that they suggest. So that is one big part of this session as well. We want to mobilize stakeholders like yourself also participating in this session to prioritize women's health, and also to make the outcomes of this session known to people who might not be in this room or in this virtual room, so to say. And how can we make more noise about prioritizing women's health in national health budgets? The session aligns with the Sustainable Development Goals, with Family Planning 2030, Universal Health Coverage, and the African Union Agenda 2030. And the ultimate goal of this session is to catalyze action to fund the future of women's health. So with this session, we don't want to be a talk shop only. We want to take the lessons learned as action point moving forward. As a coalition, we are also developing a position paper on this same topic, and we'll have an in-person session at the sidelines of the Africa Health Business Symposium in Nigeria in mid-July. So all these three sources and data sources and collection sources will feed into each other to hopefully by end of July we have a very strong position on this that we can use and to lobby and advocate for more investments in women's health in Africa. So without further ado, it is my pleasure to introduce our first speaker, Dr. Matiko Riru. He's a medical doctor and a health economist. He's the Associate Director, Health Financing at the Clinton Health Access Initiative. So when we talk health financing, he's the guy to go to. He's based in Nairobi, Kenya, and he leads technical support for health financing reforms in sub-Saharan Africa. And he fosters strategic partnerships with regional institutions for cross-country knowledge and exchange. In addition, amongst many other things, he also champions value-based care in Africa. Dr. Matiku, very welcome. Happy to have you on board.
Thank you. Thank you, Marlos. Thank you, Marlos, and definitely happy to be here today talking about, this very interesting topic that I know a number of us, and especially the participants, it's an item of interest on so many levels. A number of people ask, but why specifically do we maybe a focus on women? Because it's there's a compounding gain from a number of levels. One, we acknowledge that most of the health sector or healthcare women face a lot more, maybe disproportionately in terms of the healthcare challenges, more than men. And then the other interesting thing is, and not only is the care for them, but in most cases it means more to the children, especially in our setting where women are primary caregivers in most cases for the children. So the health of women not only means health for them, but it means for children as well. So investments in women health then has a compounding gain, especially when we're looking at how that affects households and more so around child health and the overall gain in terms of the economic gain. So that's that's the sort of underpinning conversation that I think would be interesting to have. But then we are at an interesting point in for those of us who work in global health, because for a very long time there's been great support, and especially the area of women health, from a number of funders. And we've seen that decline, and I think this year now marked a major decline in terms of funding in funding for women health, not only women health, but across other sectors. But for the conversation that we're having today, talking about women health, then it calls for a number of other interventions. I know for those of us who've been working in this space for quite some time, we started talking about donor transition probably 10 years ago. I don't think it ever at no one point did it crystallize that what it will mean for us to think about how donor transition than it is now, to actually have to think about after the fact, because earlier on we had the opportunity to think about it before the fact, but now we have to think about it after the fact. And so that calls for then so this goes, then what comes in? There is always the bigger conversation around, let's think innovatively around how we finance care. But sometimes the word innovative or innovation throws people off, because then people try thinking about very complex items that we need to think about for us to achieve this. But it's important for us to just maybe have a lens of thinking about what does that actually mean in terms of innovation. So I'll probably walk through that kind of perspective, look through what are the countries doing across the continent to address the current challenge that we do have around funding cuts, but of course going back to some of the institutional arrangements that they have put in place and how then that is being probably fast-tracked based on the challenges that they're having right now with the funding cuts. Then the next bit that will be interesting to talk about is how beyond the government interventions, how is the private sector coming in, and what are some of the areas that we can think about? But finally, talk about the whole essence about accountability, that we are putting all this. How do we make sure that we have accountable mechanisms of ensuring accountability to drive the gains that we want, especially maternal health outcomes? So I think, pulling back to what I mentioned earlier around innovation, I think it's all about trying to look at what is the overall goal that we want to achieve in any form of financing mechanism, or whatever area that we want to do. And I know all of us who are here, at least most of us, are working within the global health space, and we know that there are three key outcomes of interest, or three key goals of any health system. So everything we do, our key goals should be, let's improve health outcomes. So that means let's as very much as possible keep people, healthy, but those who are sick can get quality care to enable them get well, and even those disabled can live a comfortable life within the setting. So making sure that we improve health outcomes at the very least. And so, especially for women, then we're looking at different dimensions. Either we're talking about women cancers, or even the reproductive health cycle, where we're looking at how do we make sure that they carry their pregnancies safely all the way to the 9 months and get them out safely. So creating mechanisms and financing mechanisms that are sure that we get that part of that we do get. So that's health outcomes. The second goal that every healthcare system has is reduced, what we're calling financial risk protection. So financial risk protection means let's ensure that when women or any person in the population is seeking care, they don't have to slide into poverty. And so making sure that there are prepaid mechanisms, or mechanisms that ensure that by the time they're seeking care, they don't have to forgo food or other elements for them to seek care, or they don't have to to pay according to how they need to face what we call in catastrophic health expenditure. So the third element is equity, and equity is about how do we address the sort of vulnerable populations, and especially populations that are disproportionately affected by some of the health challenges that we're thinking about. And so women tend to be disproportionately affected by a number of other challenges, health challenges that we need to address, that then call for us to, as we shape our health systems, then we need to take care of elements that women are thinking about. And so when you look at those three elements, how are governments moving and how are different governments shaping that? And there are two key items that we have to think about in financing. The one is, how do we mobilize more resources? So to mobilize more resources, there are all interventions that different countries have got into. I mean, the traditional mechanism is let's use taxes to purchase care on behalf of population, and also let's create a social health insurance mechanism. So that has been going on for quite a while. But even within that, there are all other elements around how do we actually mobilize more resources innovatively to feed into that similar mechanisms. And that's why we're having all these conversations around, do we have sin taxes or not? And of course, that has implications, especially because it's not as much as health will benefit, but there are other trade implications in terms of taxes collected and all that. And there's a whole debate around how that has an impact in terms of macroeconomics. And those are some approaches that a number of countries are using. And also, be it some of the taxes that they are being imposed on, certain items of interest, let's say, mobile levies, oil levies, or traffic fines. And I think a number of countries have built that sort of mechanism of building more responsive or mechanism of bringing in money to address some of those challenges. But so there are all this in terms of how we bring money in. But usually we know that it's not enough that you have the money in, because you can have as much money, but in most cases, the challenge comes around how do you translate that money to actually delivering care and achieving the outcomes of interest that we're looking at. And I highlighted the outcomes of interest that we're looking at the three. That's improving health outcomes, financial risk protection, and equity. So how do we achieve that? Now comes to the next level of how do we utilize those funds efficiently to address them. So the key lever and in between, even before utilization, is what sort of mechanism, pooling mechanism that we do have. So making sure that as you're putting together resources, it cuts across all the risk groups, that we're not putting maybe old people together or young people together or mothers together, because we need to be cognizant of how we have a risk mix that enables us, our resources, to be pooled in a very efficient way. And so what most countries then are working towards is a more centralized prepaid mechanism, either national system or a national health insurance, but also others that, like Nigeria currently working on what we're calling swaps, the sector-wide approach, as one of the basket fund. Like, how do we get all funds being put together either by external funders or in country, and to make sure that we achieve the outcomes of interest. And I think it's an interesting case right now as the government of Nigeria tries to put that together at federal level, and also looking to see how that trickles down to the states. So that happens. Then we need to think about how then does that translate into services. And so it goes to how we spend. So we are allocating, and now we are thinking about how do we spend the money efficiently. And by that we mean, how clear are we in prioritizing services, especially around how we define benefits packages. A number of countries have institutionalized mechanisms that define the benefits packages. I know Kenya recently just inaugurated the health benefits package and tariffs advisory platform that is going to be, to be this entity that decides what goes in, what goes out, because then we need to prioritize high interventions that are based on evidence, either on disease burdens, on cost effectiveness, and all other measures, and one of them being equity. And then so that becomes an interesting thing that we need to think about. In a number of countries, Rwanda has institutionalized the Health Benefits Package Committee that helps in that whole mechanism to achieve such level of prioritization and efficiency, to ensure that all that you raised actually translates to outcomes of interest. So on top of the benefits, the benefits package, the other element that a number of countries are having to address is how do we purchase, and so how do we buy. How do we make sure that how we spend our resources actually translate to the outcomes of interest, is the provider payment mechanisms. And I know one of the most lauded mechanisms that a number of them have been working on, although it presents a number of challenges, is the results-based financing. So how do we make sure that that we are putting in money, but there's an accountability mechanism that putting in money that gets us the resources the results that we actually need. And so creating clear mechanisms, but again, we have to acknowledge some of the challenges that exist in this. Is weaker data systems present a challenge in terms of how you can have results-based financing, because then we need to track you need to measure what you're going to pay for and have robust data systems. And so what will be interesting, and a number of countries are trying to institutionalize digital transformation that captures all that data to enable them to be able to pay for results. And that takes me to even the other layer that I talked about around how do we ensure, even as we talk about that, is we have a clear transparency and accountability mechanisms. It's just around what is emerging now as a bigger conversation around how do we shape data systems that capture financial flows and non-financial flows, non-financial data flows. So non-financial data flows, we're talking about health data. So in most cases, and a number of countries have financial data systems that are flowing. I know integrated financial management systems, or IFMIS. A number of countries will have that. Then they'll have DIHS2 on the other end. But so money is flowing through mechanisms, social health insurance, government, and donors that are sending money to the health facilities. And that is well accounted for through financial systems. But on the other end, we have data flowing to the Ministry of Health from facilities, but the two never communicate at any point. And so it's becoming a whole interesting point that how do we make sure that this, I know it's quite an overkill to imagine that we'll ever merge the two, that we have maybe DHIS and IFMIS literally in the same room, but it will be interesting for us to create certain layers that recognize this, such that we're able to see where the money is going and where the health data is coming, so that we can invest where it's supposed to be. That I gave this money to a particular health facility or state or region or county, and this is what I got back in terms of health outcomes. So that becomes an interesting thing, and I know a number of people are pulling towards that, and I think it's one of the key areas that we should be thinking about in terms of how well we create clear accountability mechanisms that ensure that how we invest is actually very clear in terms of how we get that. But what about the private sector? Some of the key elements that come in most cases in private sector is just a number of private sector players feel they don't understand the policy side of things. So the innovators that are coming up with all these innovative mechanisms, either digital systems that I've mentioned before, is quite a big gap. But then there are all these issues around what are the regulatory space look like to enable them come in, and especially as we talk about funding cuts. And traditionally, what has happened is to get an innovation or any sort of product into the market, especially in Africa and other low-middle income countries, especially with the traditional funding mechanisms that we have, maybe global financing facilities, financing certain aspects. The bigger challenge comes in, there's always a requirement around, it needs to be all these regulatory mechanisms, FDA approved, and the many other layers. Well, they're definitely good things to think about, because then we have to think about the patient safety. But I think we also have to acknowledge that it creates quite a number of layers or bottlenecks to having newer innovations across the continent, or even driving or incentivizing that to make it work, especially given that the fact that there are a number of people that are working within this space. So getting those who are closer to the problem address some of those challenges. And so the regulatory space acts as a big hurdle to private sector being part of or in the innovation space. Even if we're talking about microfinance or affordable insurance, there's still regulatory hurdles to actually get that through. So the regulatory space still remains a challenge, and I know a number of countries are trying to work on that. And finally, the issue around PPPs, so private-public partnerships, have been one of the key items that people have been pushing for quite a while now. And I think it's even more interesting right now as we think about the funding cuts, that we could be thinking about how do we incentivize the private sector to partner with the public sector for them to actually work together. But of course, there are all these challenges around the public financing, the PFM or public financial management systems, how they're built. They're very sort of rigid in a way that they interact with the private sector. So sometimes private sector involvement comes up with a lot of challenges. So it will be interesting for us to think about how do we create legal instruments that are actually enabling clear interaction between private sector and public sector. And I think that will be one of the key elements to think about. And so I'll probably wish to stop there. And I know there's quite a number of questions that will come. I just wanted to give quick opening remarks and give space for the other panelists that can walk us through a number of items, and then let the teams, I know there could be a couple of things I mentioned or maybe didn't mention that might come up from the participants. Happy to answer them or get to a conversation to address some of them. So really looking forward to this conversation. Thank you.
Thank you very much, Dr. Ari. I've noticed, and also the example about pools, risk pooling, but having not all risks in one pool, so you spread the risk in a way. And I'm also looking forward to questions from the crowd on this. And I also noticed your last, which I think is a very important one. We need to have enabling legal instruments that allow for workable public funding mechanisms that actually working with the private sector. It's good to create transparency, accountability. You need to have that in place, but it should not be counterproductive. So how can we create, I don't want to say a middle way, but a way that works for the private sector, also in terms of timelines, bureaucracies, hurdles to take, but it's also transparent and accountable enough that it means it set the right governance systems from the public sector side. So yeah, indeed, I'm looking forward to going more into that with you as well. And also learning more about your experience, where you've seen success, where have you seen African governments actually increase domestic funding, maybe not in the last quarter, let's say, of urgency that we are all talking about it, but even in all the years before where you have lobbied, advocated for, you know, innovative financing, and where actually did the government bite the bullet and put in more tax fund or whatever to fund healthcare. So I think that is definitely something that will come up. Thank you very much for now. I want to go to our second speaker, Ms. Vuyo Njekula. Very welcome, Vuyo. I hope you're there.
I'm here. I'm just turning on my camera.
Okay, let me read a brief biography so that the people in the virtual space also know who you are. Vuyo is the Director for External Affairs at MSD Sub-Saharan Africa. She leads a team focused on health system strengthening and expanding patient access to MSD's innovative portfolio in Sub-Saharan Africa. Some of that are also focusing on women's health, so looking forward to hearing from you on that. Actually, she's a former diplomat, was based in Washington, D.C., and is professional in energy and NGO sector. So since you've been a diplomat, you've been on the other side. So looking forward to your views there as we are talking about domestic funding. And you're very passionate about innovation as a solution for social and health challenges in Africa. So very welcome, Vuyo. It's a pleasure to have you with us. To also hear from the private sector point of view about this topic. And I'm sure the supplies, the products that MSD has been providing to the African continent has partially or has been donor funded and has been affected with the recent funding cuts. I would like to know how does a company like MSD deal with these challenges that come up, and what have you experienced the last period? And how do you partner with governments to ensure that, you know, accessibility should not be or is not affected too much? So yeah, that's my first question to you.
Okay, first and very difficult one. Thank you, Milus, and thank you so much for having me today. So I represent MSD. MSD stands for Merck Sharp and Dome. We are known as Merck in North America. We are headquartered in New Jersey, operating in more than 70 countries globally with around 69,000 employees. And really what we do is we use the power of leading edge science to save and improve lives across the world, focusing predominantly on the manufacturing of life-saving vaccines and treatments or medicines. So our footprint in Africa goes back over 5 decades. I would say by far the biggest product or areas where we have had an impact include historically HIV. Today, it's more in the prevention of cervical cancer through the HPV vaccine, which is availed through Gavi as well as UNICEF. And of course, we also are the manufacturers of the most preeminent and impactful oncology product we have seen in decades, with multiple indications, and that is pembrolizumab. So in terms of the question of how do we respond to the changes, I think for us, it's just about maintaining a deep level of focus on doing what we've always done. We've always tried to work with the patient in mind, focusing on unmet health needs. And so we'll continue to develop new medicines and vaccines that address unmet need. But we are also acutely aware of the fact that it makes no sense to develop this breakthrough innovation without having any access. And so we will continue to work on our partnerships through Gavi and UNICEF and others to avail our technologies at an affordable price to countries that need it most, including low to middle income countries as well as middle income countries. When we look at some of the shifts that have taken place in global funding, I think one can firstly say, uh-oh, it's the worst thing ever. Or one could also say, what can we do now? And I've heard many people say, never let a crisis go to waste. I think it's a time that really forces us to reflect as Africans on how we start leading our own solutions to our own challenges. And I think that more than a challenge, it also represents a unique opportunity in our time to take greater control of our health destiny as a continent. If we consider what happened during COVID-19 and some of the drives we've had to improve our health security, I see this as similar in the moment that we're in now. And I really believe that there are untapped opportunities to improve the funding landscape in Africa. And I think that it would be really well spent if these efforts were focused on women's health and in particular, women's cancers. So just to recap some of the key things that Marloes mentioned, only 3 countries in Africa have met the targets set by the Abuja Declaration. Most of the countries across Africa have a strong political commitment to universal health coverage, but due to resource constraints, the coverage provided tends to be thin and remains largely unoptimized or lacking in its level of richness in terms of benefits to the general population. Now, if we look at even the funding that we have had through universal health coverage in many countries on the continent, this has been augmented by donor funding. And of course, the funding has been largely allocated to the prevention and treatment of infectious disease, HIV, TB, etc. Now, this happens against a backdrop of a rising tide of non-communicable diseases and alarming rates of growth of cancers. And so something is not going to work. Things are not working, and there's a brokenness that we have to accept and acknowledge that we have. And I think what it says is that we have to start doing things differently. And I would even argue be a little bit radical in the way that we approach health financing across the continent. And I think this has to start with looking at and addressing really the areas which we have shied away from historically. And I think that is particularly for women's cancers, except for the area of prevention, as well as broader NCDs as well. And why women? A McKinsey research shows that closing the gap in women's healthcare could generate more than $25 billion in annual GDP across Africa by 2040. We also know that Africa boasts the highest percentage of female entrepreneurs in the world, with approximately 1 in 4 women engaged in entrepreneurial activity. In addition, African women spend 3 times as much time as men taking care of others, especially children and the elderly. And we know that according to the African Development Bank, women tend to reinvest almost 90% of their income into the education, health, and nutrition of their families and communities. And so I like the statement that investing in women's health is a no-regret move. It by far has the greatest multiplier effect when you think about economic growth and development. And if you look at some of the statistics around women's health, it's also quite scary. We have the highest growing rates of cervical cancer, which is the leading cause of deaths as a result of cancer on the continent. And this is something that's a preventable disease. And we also have an unacceptably high rate of breast cancer as well. So I painted some pictures about why women. I painted some pictures about the brokenness we have in terms of health financing in Africa. So what are the potential ways we could rethink our approach? So Africa, and I think Marloes has spoken to it, as well as my previous esteemed panelist, African countries exhibit some of the highest out-of-pocket health expenditure rates globally, often exceeding 30% of total health expenditure. In fact, according to the WHO, in a report published in 2021, 11 WHO Afro countries had out-of-pocket payments exceeding 50% of total health expenditure. And in 3 countries, they surpassed 70%. Now, for me, this is astonishing, because what it means is that even as we're not meeting our targets in terms of the Abuja Declaration, and even though we're not able to implement rich benefits within the context of universal health coverage, there is a lot of money in this continent going to health. But this money is disorganized, it's fragmented, and it's led and utilized by consumers who, quite frankly, have information asymmetry and no means of doing a proper value assessment framework or health technology assessment. So I think the first key opportunity we have is the ability to pull all the resources that are spending money on health to implement and improve on potential risk pooling. The second area, I think, which is important for us to consider is the amount of money of health expenditure that is led by corporates. Corporates in many countries across the continent provide pay for the health of their employees and fund their own unique health insurance products. Whether it be banks pulling together, and I know that there's some initiatives underway in Ghana for this, or whether it's just about connecting with an international insurance agency like Cigna and flying some of their top employees out of the country when they have a health event. But imagine we manage to take the taxes that are meant for health, predominantly sin taxes, the money that's afforded by the national treasury or the national budget to health, take all of this or some of this out-of-pocket expenditure, as well as corporate contributions and other health insurance contributions, and pull them together. I think what would change is that even if it's not managed by government in its entirety, what would change is that we'd have a health savings culture on the continent. And if we applied some form of value assessment and cost effectiveness study with the pooled funds, it would actually mean that individual consumers would have to pay less for health. So the first thing I think that's critical is doing a full analysis of all the health expenditure that exists in the countries across the public and private sector and amongst individual consumers, and really start to promote the galvanizing of these resources so that we're able to effect risk pooling. The second thing I think that's really important is to have a slight mindset shift. So currently, if you look at universal health coverage and the way governments, spend their health, they believe it is it's solely their responsibility. And so we have the typical and traditional model of everybody paying a particular portion or a fixed fee to a national health insurance scheme. And on the back of that, having the ability to access some services and products without any cost, or at least with no fee at point of care. I think we have to move away from this. Universal health coverage does not have to mean that everything is free at the point of care. It also doesn't have to mean that it is the same for everyone. I think that universal health coverage provides an opportunity to enable social solidarity and cross-subsidization between those who have more and those who have less. And I believe that if governments had to start considering and started negotiating for all the products that are required in a health system, including innovation, and said to manufacturers such as ourselves, we have a disease burden in breast cancer of X amount. We have seen through the data that we've collected and through our cancer registries, which is also important, that most women are presenting at this stage. We would like to be able to procure your product. And this is the volume that we're potentially looking at. What price could you avail us? We could actually come to the party, and I think many manufacturers could, But then the funding of it doesn't have to come from government. Individual patients diagnosed with breast cancer could tap into a government program and actually pay based on the lower negotiated price by government. And through their payment, because they are in a position to and have the means, could subsidize others that don't have the same capability or the same access to resources. So for me, really, this is what I believe and what we believe could be a significant game changer in rethinking how we procure and how we provide health services in certain national contexts. And yeah, just to summarize, before I conclude, I think the first thing is, let's accept that it's not government responsibility alone. Resources are too limited. UHC does not have to translate to free, to no cost at point of care or service. We need to make use of various funding mechanisms to increase our ability to pool risk, including health insurance, both in public and private, out-of-pocket expenditure, as well as corporate expenditure on health. And I think we need to start bringing in legislative instruments to actually enforce a culture of health savings. It should be mandatory for every working person to have a form of comprehensive health insurance from the time they start working, so that you have effective risk pooling, and those who are paying earlier in their lives and are not as sick can fund those who are older and may need more health services. And I think lastly, and as I said before, this needs to be based on the principle of social solidarity. The young should pay to subsidize the old, the young and healthy, and those who have more should pay more to subsidize those who have less. And I believe that this is a system that unites our health expenditure and really can see improved health outcomes, and raise the ability to raise domestic resources and stop operating in silos, each of us individually or through corporates trying to do our own thing, and not benefiting from the economies of scales of national procurement mechanisms. Thank you.
Thank you very much, Ruyo. I'm hearing you also concluding with the same message or a similar message as Dr. Matiko about pool procurement and social solidarity. In Kenya, that has recently happened more with now the Social Health Authority, where of the formerly employed people, 2.75% of the gross salary is already going since October last year, actually, this pooled group. There are a lot of practical challenges with it in terms of reimbursing healthcare providers, public sector, but also private sector. So I think and maybe that's a follow-up question for the open forum as well. How do we ensure also that efficiency is there and that you don't create a negative monopoly position that prevents quality to prevail, both in terms of service provision, but also in terms of payments to the healthcare providers that offer the services? Because I have heard, and we're seeing that a lot of private providers are getting into financial challenges because the repayment or the reimbursement rate of the national health insurer in this case is taking so long, or is using certain tactics to delay payments that is counterproductive. So in essence, I think the model, I think we would all agree with it. It's a good way. Those with an ability to pay will cover those with no. The older will be taken care for by the youngers who are relatively healthy. That model, but how do you make it working in practice, and also to make sure that those who contribute get value of money, and also that you don't over punish those who are already in official employment. Don't forget, how do we target those informal sector people that are not contributing tax in general, or not through their monthly pays, so to say? But how do you create an equitable system that those who are not following the official lines are also contributing to this fund? But maybe that is something we can bring up in the forum. For now, I want to thank you very much, and I think I really liked also the suggestion that you brought about a pooled, from your multinational point of view, as having an agreement with government that, for example, breast cancer patients can tap into that pool to get subsidized prices for their care. So I think that is a great suggestion and a good idea, and I hope that will be worked out so that those type of partnerships with private sector can really foster into access, apart from even a social health insurance cover, But yeah, that is something to explore. So thank you very much for now. I'm sure we will get back to you. I would like to introduce our third speaker for now. That is Dr. Lucy Mazianga Mazaba. She's the Regional Director of the Africa CDC here in East Africa. Dr. Lucy, I hope you are with us.
Yes, I'm still with you.
Yeah, great. Thank you very much. Let me allow me to introduce you to our participants, and then I would like to share our first question with you from another point of view, the public sector point of view, and the regional Africa CDC hat that you are wearing. Apart from the regional director for the Eastern part of the Africa CDC, you're the former director of public health policy at the Zambia National Health Institute, with over 20 years of experience in public health, virology, and epidemiology. In addition, I found this an interesting fact. You're the board chair of the Special Olympics in Zambia, and also the chair of the Women in Global Health Zambia chapter, and a recipient of the Stanbic Bank Zambia Anakazi Women in Health Award. Dr. Lucy, you're very welcome. We've heard from private sector. We have heard from an implementer in health financing. Now, love to hear from you from a more regional perspective and from the public sector point of view. What is your experience, or what are your views on the impact of funding cuts? And if we're talking about moving away from donor dependency to ownership, in your experience, how have countries across Africa dealt with this move from donor dependency to greater domestic ownership, especially in regards to critical services like sexual reproductive health and maternal health? And what is the Africa CDC point of stand in that one? Over to you.
Thank you very much, Malo, for that important question. And thank you very much for the introduction. This donor cut, I think, has been taken by people or organizations or countries or leadership in different strides. With some still in the dream mode and thinking it will resolve itself, with others already jumping to the fore and seeing how to realign, their space in terms of the financial fiscal space regards health. And we see encouragingly a lot of countries looking at finding innovative solutions to this plight. And we are at different stages. But before I just go into the details of that, I think what's important to note is that health security cannot be outsourced. And I think for a very long time on the continent, we've been outsourcing because we've been solely dependent on external resources. But we saw in the COVID-19, for instance, that countries that were able to demonstrate strong political will in the COVID-19 were responsive more effectively compared to the others. And looking at the lessons we learned from this COVID-19, I think it's important to note that we need to encourage our political level, who's responsible for governance and policy, and mostly the heads of state and government, but also the high level leadership in that space, to prioritize health security as a core pillar of national security. We need to look at health security as a specific or specialized entity, but it is a major component of national security and development. And we need to ensure that they have good commitments in terms of their budgets relating to this thought. I'd like to just bring to the attention that at Africa CDC, we are working with the member states, and we are at the forefront of advocating for sustainable health financing within the member states, as regions and as the continent. particularly promoting a shift from donor dependency to greater domestic ownership. And this aligns with the AU's vision of health sovereignty, resilience, and accountability. And the member states are a part of this decision. We have seen some good strides in terms of member states across the continent with a positive momentum towards integrating increasingly sexual reproductive health and maternal health into their national plans and health insurance schemes. We see countries like Rwanda and Kenya, for instance, who are pushing into increasing the integration of their maternal health systems and their sexual reproductive health systems into existing structures. We've also seen a growing trend in investments regards local manufacturing of maternal and sexual reproductive health commodities in some of the member states. And this, I'm sure you agree with me, will definitely go a long way in reducing dependency on donor-funded procurements and indeed securing the supply chains. It is the beginning, but I think there's in the discussions that we're having, more and more countries are having an interest in that space, also looking at a regional perspectives, leveraging on regional economic communities to help focus in that direction. We are beginning to see a lot of public financial management reforms, including a focus on tracking spending and improved alignment between the health priorities and the national budget. We've seen countries relook at their budgets, not just in the Ministry of Health, but also at the national budget, and realigning the resources so that their health security is maintained, which is a good thing. I've seen that in places like Rwanda, I speak more in the eastern region, but I know that even other countries in the northern part of the continent and some in the southern part are also taking these approaches. So one of the things that we're doing as the Africa CDC is really supporting this shift by embedding women's health into universal health coverage frameworks. Sorry, just hold on. Sorry about that. I'm sharing a room. So Africa CDC really supports the shift by embedding women's health in universal health coverage frameworks and promoting peer learning between member states. And we see a lot of countries embracing this approach and adapting the agenda to their national space. There are quite a number of promising strategies, and recently the Africa CDC, I think that was in March 2025, launched what we call the Africa Health Financing in the new era for Africa. And this document really guides how countries can strategically shift towards sustainability, recognizing the importance of self-reliance and resistance with a focus on strengthening domestic health systems. In this document, which is being embraced by many member states who are trying to adapt it to their context, we focus on 3 pillars, and one of those is domestic financing, increasing domestic financing, which it will help us focus on shifting from donor dependence to country-led and country-owned health financing. The second pillar looks at innovative financing, where you expand the fiscal space for health using non-traditional mechanisms such as introducing or scaling health taxes on things like tobacco, alcohol, carbonated drinks, and so on and so forth. Implementing solidarity levies such as telecom or airline ticket levies, and exploring diaspora bonds, endowment funds, philanthropic contributions, and using pay for performance and result-based financing models to incentivize outcomes. We're seeing more and more member states pushing towards this agenda. Blended financing and investment is another focus that we are pushing and is already being embraced by some of the member states. And this is where countries can leverage public-private
Sorry, Dr. Lucy, you went on mute and your camera went off.
Apologies, I was just trying to get some, I think there was a lot of background noise, but also to just say blended financing and investment is another area of focus that we have been pushing and is being embraced by many of the member states, where countries can really leverage on public, private, and development financing to crowd in, additional resources. We're looking at countries creating enabling environments for public-private partnerships. I know there was a discussion on private sector in the space, but public-private partnership in health infrastructure, in manufacturing and innovation is another area that is being pushed. And we also looking at mechanisms that include utilization of guarantees, concessional loans, and risk-sharing mechanisms so that we de-risk investment and engage multi-sectoral development banks into supporting the domestic financing space. And supporting things like blended platforms, such as the Africa Food Procurement mechanism. And I heard one of my colleagues talking through the issues of pooled procurement mechanisms as another innovative way of ensuring that we leverage on the resources that we have and reduce the costs or the spending on health. The Africa CDC has also established what we are calling the Africa Epidemics Fund to pool resources that can be utilized by member states in health emergency setup. And we saw in the COVID-19 how women were, affected severely due to the COVID-19, them being the ones who are looking after the caregivers, but also having to balance between caregiving and mobilizing personal family resources and so on and so forth. So all in all, what I'm saying is that we are encouraging the shift from donor dependency to domestic ownership, and we're happy to see that a number of countries are embracing this and have started to move in that direction. Thank you very much.
Thank you very much, Dr. Lucy. I noticed that you mentioned the health financing document that the Africa CDC has developed, and I believe that is available online, if I'm not mistaken.
Yes, the document is online. I will share the link to the document. It's accessible by anybody and everybody.
Thank you very much. I'd love to hear from you in the Q&A session, some questions about the best and worst performance. Maybe I'm not sure of naming names, or what makes it easy for a country to adopt some of the advice that the Africa CDC takes, or gives in terms of domestic funding. What are the challenges that you have maybe found in your advisory role as well to countries, and what limits sometimes the uptake of it? But I suggest we get back to that in the open forum. For now, I want to thank you very much, and then I want to give the floor to our last speaker of the day. That is Dr. Katari Ndirangu. He's chief of party at JPIGO. He's an accomplished obstetrician gynecologist with more than 25 years of experience in clinical care, research, and public health. As mentioned, he's the chief of party, and he's that of the Momentum Country and Global Leadership Project in Kenya. And he leads efforts to support the Ministry of Health in improving maternal, newborn, and child health, and also nutrition through high impact interventions. I know you've also been the former global director of family planning, so also a wealth of experience in that area. And you're a strong advocate for stronger health systems and increased domestic investments, especially for women's and children's health. So, Dr. Kitari, very happy to have you with us. welcome to the session.
Yeah, thank you, Marlos, and hello, our audience. Really appreciate this opportunity. And maybe even before I dive into what JPIGO has done in terms of being able to pivot to the evolving trends in funding, let me also speak to the fact that, JPIGO has a huge presence in many countries, especially in sub-Saharan Africa, both in Francophone and Anglophone, and also there is from corners of this continent. And one of the things is that just in January this year, it had a more than 4,000 workforce spread across perhaps 46 countries across the globe. But when this really disruption happens so suddenly, of course, that meant just like any other NGO and many other organizations, of course, it was affected and felt the impact of the funding cuts. And primarily because while we've been talking about diversifying funding for a good number of years, our largest support or our largest donors has remained the US government through primarily USAID. And so you find that some countries don't have any other sources of funding beyond what USAID is able to provide. And so out of that, then that meant there will be staff reduction, the reduction in force. That also affected me, like Marlos mentioned. I was the immediate former, global director for family planning. But nonetheless, I think I just want to perhaps mention that because of its work with, directly with governments through the ministries of health, and in many countries, even outside the ministries of health, that, this, as we've been seeing, I mean, the ecosystem has been evolving. COVID-19 has been mentioned a lot of times by the previous panelists, so I don't need to go there, but we know that these disruptions have been coming, and I do believe they will not stop. So it's just for us, like we have mentioned, how do we take advantage of the crisis and make sure that we optimize the opportunities? So you'll find that, in the countries that we are working, challenges with, commodities and supplies and equipment, that have the gap has become even more acute in terms of the decreased funding, but also increased pressure on government systems. And also, obviously, we know that, unlike has been mentioned previously, is the ones that are probably already disadvantaged are the ones that get hit the hardest. So I don't know, for those who are watching, the news and how the events have been unfolding, JPIGO, as an affiliate of the Johns Hopkins University, of course, was not cushioned against the huge cutting funds that the US, the Trump administration gave. I think JHU lost over $800 million in grants and whatever else they're doing. So, like I said, globally, I think the workforce for JPIGO was probably reduced by half. But of course, a little more is just the actual disruption of service delivery in the countries that you're working in, inability to be able to provide what you were doing before in terms of being able to reach the ones who are hard to reach, the ones who are most disadvantaged, to be able to get services that are really affordable. And like I mentioned earlier, as you know, broadly, USAID have historically been the major funder in FPRH. We know that then women did get affected, access to services. And I think the other is that, there were estimates that with the abrupt funding, there would be, of course, an increase in maternal deaths, and internal pregnancy, and especially in countries we are working in. For example, I'll just give this example that family planning, all of a sudden, from the USG perspective, is not a life-saving intervention. Yet we know different, of course. And so out of our conversations is that then whatever remained, whatever was placed back online, you know, after the initial stop work order, the terminations and whatever else, is that then we shouldn't speak about family planning. Yet you know that perhaps for 2 out of 5 women or more will survive pregnancy-related mortality, or will not die because of pregnancy, as if they're using contraception, and especially because of unintended pregnancy or mistimed pregnancies. So really having seen that is for us then as an organization, and I mentioned earlier, you know, we've really been seeing the trends and asking ourselves, how do we diversify our funding? You know, we already have a rich network of donors, not just the US government, but how do we then intensify these efforts? So really, that's one of the things, is that the urgency in terms of making sure that that happens, strengthening existing partnerships with philanthropic foundations, bilateral donors other than the US, and also the private sector players. And I think we've effectively been able to do that, you know, as an organization, but also in the countries we are working, just being able to see us with the government, see who are these or other potential opportunities where funding can come from. Of course, not forgetting public resources, because I think a lot has been mentioned, you know, earlier. I think also trying to identify, you know, how do we improve the country level fiscal space? And I think Dr. Matiko did mention this very articulately. And I think even as we work, for example, in this country, even at a subnational level, just identifying who are the key players in this space. And I think the biggest thing that we've also been, because we've been advocates for this, is integrated, you know, service delivery, program models that encourage sustainability. And I think as we worked immediately after the stop work order and a couple of months thereafter, just seeing the impact that this has had. For example, we know that people who require HIV services tend to go in a separate entity where the rest of the facilities don't necessarily engage in, and most of these are supported by you know, donated funds. So trying to see how we can reorganize those services so that then, you know, every individual is able to get the services that they need and centered on them, on their care. Of course, we do also appreciate and recognize the fact that the health workforce is low, and also it's probably, you know, stretched to the limit. But I think it's also asking ourselves, under the circumstances, how do you utilize and optimize the resources that we have, so that then we can be able to give those people the citizenry of this continent. And I think as citizens of this continent, really, we know that we can do this. It's just that this disruption, and I think I'll go back to what we have said, we shouldn't lose this opportunity, not let this you know, crisis and go without taking advantage of the opportunities that it presents. In addition, is just to ask ourselves is, and I know again the previous speakers have talked a lot about it, and that's the beauty of being the last speaker, is when you look at the private sector, and I think again as an organization, that's one space we've really been you know, pivoting to, leaning towards, making sure that our partnerships for service delivery, this quality of care, you know, I think when you look at across this continent, for example, the pharmacy tends to be a good, for proportion of users, tends to be a good port of call. And I think it's to make sure that then, what is the quality of care that they are getting there? We've seen that even in the, you know, Francophone, even in fragile settings, the pharmacy being very, very critical in terms of service delivery, especially to the younger population, and also, you know, the youth, adolescents, and making sure that then they're able to get that. So we've really been partnering with the pharmacy space. In Kenya, we've worked very successfully in terms of prevention of HIV infection through pre-exposure prophylaxis, and the pharmacy has been a critical player in that. And we've extended that to look at the pharmacy, how does it, again, as a family planning source, how do we make sure that then the services are good and their quality, and they are also, of course, aligned with the policies of the country. And here I'll also add the element of digital health, which again, one of the things that we learned from COVID is that doing things in a digital manner then gives us beautiful access, gives us access to people who would not have had that. And so working with pharmacies through the e-pharmacy platform, we also really been able to see great successes in terms of being able to get users to actually access services through that platform, telemedicine, digital counseling, but also then, the supply of commodities directed to the consumer. I think that's something, of course, that's really more workable in urban settings where that can be a viable business model for many users. But I think even in the more rural areas, there are opportunities for us to be innovative in how we do things and do things differently. I think as an organization too, is also thinking, how do we structure our conversations, with those who care to listen? And I think that what has been mentioned a lot is we look at, of course, the high wealth net individuals, but I think we have other individuals, corporate entities in our localities. But how do we structure those conversations so that they can see the value of them investing in the health of women? And I think, again, I am not here to convince anyone on the value, the great value of investing in the welfare and well-being of women, because we do know that that changes communities, that changes societies tremendously. And that's one of the biggest avenues for accelerating development. So how do we structure these conversations? Are we able to show that, as we are engaging them? And it's something I really had in one of the engagements in the subnational levels in Kenya. Like, do we view women as customers, for example? It's a corporate entity we are engaging. And obviously, they need to understand that if women continue dying while giving birth, then they are losing customers. Their customer base is shrinking. But not just that. What is their corporate social investment in this? So that they also start seeing, if we make my neighborhood healthy, then I'll be able to develop. I'll be able to get labor when I need it. We really need to structure those conversations. I think even in the other sectors, for example, when you're approaching the national treasuries or ministries of finance, is also trying to demonstrate, if we invest this amount here now, you're going to save this much later in the country, so that you're able to demonstrate that these soft things that health is, health is not seen as a big thing, that they can actually start appreciating the value of, ill health for women and children, the value of them being taken out of being able to be economically empowered, and also appreciating the fact that economic empowerment and health really are twins, and they affect each other. And I think it's important for us to continue being able to drive that. And I think when you're having this conversation is to identify what are these critical 2 or 3 things that we need to make sure that our leaders, our decision makers see as important, and then continue looking for ways of doing that. I already did mention perhaps a larger investment in digital health platforms. I think this continent again has huge and heavy deep mobile phone penetration and internet access, and so being able to demonstrate how to utilize this as a tool, making sure that, for example, providing information, counseling, letting them know where the easiest, the nearest place they could actually, physical place they could get services are. And I think more and more, and I know the previous speakers have spoken a lot to risk pooling and insurance, and I don't want to go deeper into that, but I think is also looking at how do we incentivize people who are, to see the value of buying insurance when they can afford it. I think there's obviously this conversation about having it as a sliding scale, so that then everybody is able to get something, everybody is able to contribute something. I do agree with the value that those who can pay should pay, but of course, what is affordable to them, so that then that can free resources for those who cannot be able to do it. Because you also need to protect those who are not able to, so that then we make sure that everybody gets their services where they need them, when they need them. I think is also trying to look at what has been happening is that looking at the previous, Trump season 1, we saw that there was something around the journey to self-reliance, and it was almost immediately supposed to have reached the destination. And then when this season now has come, with the Trump being the epicenters, we've also seen other governments, especially in Western Europe, responding in a similar manner. UK, France, Belgium, Netherlands, and really indicating that they're going to reduce their aid, foreign aid. So I think, again, it leaves us with no options other than to look and ask ourselves, what do we do? Why have we been reliant? I think, why have we been reliant on external governments and donors to manage such basic things like immunization, like family planning, like maternal and newborn health? So again, making sure that we are present to be able to ask ourselves those hard questions. I think for us too, as an organization, is also trying to see how do we encourage and get government to own many of the things that we've been doing. For example, reducing the traditional or replacing the traditional classroom training, residential training, to on-site mentorship, so that then you can be able to spread that. Obviously, the cost of mentorship at the facility is much lower than residential training, and we've also been able to demonstrate the kind of savings that then we can be able to make, so that then the surplus can go to other other necessary needs, especially within the health system. But of course, making sure that there's also increasing ownership by local health workers, so that they see, this is my problem, how can we work together to make sure that as we go forward, it is sustained. And I think one of the things is also making sure that they're transferring these skills. We are doing it in a place where they are comfortable, they don't need to be taken out of their facility. But when it's not very busy, you can actually have some skills up where skills that are not commonly practiced. You can make sure that you keep yourselves abreast in the event that an emergency happens and catches you off guard. So I think the other thing is, of course, things that have been tried before, resource-based financing, and I think that in the past has been shown to work. But how can we push that even further to make sure that it works for everyone? Community-based financing in some of those, linking savings with maternal care, so that then it is scalable for use by others in other settings. And I know there's all this thing about private, public and community partnership, making sure that then we are all seeing the value of that. And again, I'm not going to go back to what has been said, but really trying to ask ourselves, how do we do this and do it in a way that gives us a sustainable opportunity for us to deliver results, but quality results? Because I think the biggest danger that we get ourselves to, or fix ourselves to, is to get complacent with broken systems. And I think I had somewhere yesterday that resilience is really not enduring broken systems, but being able to rebuild on our own terms, on our new terms. And I think this is our opportunity to make sure that we do not lose this thing right now that we've been provided with, because this is our moment. And even as we look at, this is, in many countries, it's more than 6 decades since independence. I think we must continue insisting that Africa provides basic needs to its citizenry, because it is their right. Health is a right for everyone. I know we cannot be able to argue any other way, but also making sure that for us to make sustainable efforts, that our sustainability is really pegged on local leadership, smart financing. I think a couple of things have been mentioned, but also innovation, making sure that we are driving, and we can utilize, other, external donors to help perhaps in catalyzing some of those things, identifying what are these new innovations, are they scalable, are they workable? But once they are proven, then I think really governments and the players in the country or on the continent should be able to drive that and scale that up within and embed it within their existing programs and health interventions. I think again is that as we think about reimagining how we invest in women's health for the future, I'm reminded by what the late Professor Mahmoud Fatala, who I think 2 decades ago was the president of the International Federation of Gynecology and Obstetrics, FIGO. And he did mention at that time, which is still true today, that women are not dying because of disease we cannot treat. They are dying because societies have yet to make the decisions that women, their lives are worth saving. And I think for us, the time is now. The time is really now. The future is here. The future is now. We cannot wait any other moment for us to do the right thing. Because if we do not do, every minute we miss, every day we miss, lives are lost. And once those lives are gone, we cannot be able to get them back. And so I think I'll leave us with a question really asking ourselves, and I think it's also, for me, introspection is, how can we collectively advocate for health budgets across this continent that reflect the value of women's lives? Are women's lives worth saving? If we are convicted, then I'll challenge us, each one of us, to be thinking, what are those moments that you're creating to advocate for health, to advocate for budgetary allocation, to advocate for a health workforce that is treated with respect, to also make sure that the health workforce is also responsible and accountable to the people who have employed. And I think also the private sector, how do we bring them closer and making sure that they are feeling value, that they are valuable, constituents and contributors to the health and well-being of the citizenry of this continent. And now, again, making sure that for those that are for profit, they're really making decent, reasonable profits, that they are not being swallowed by the crazy, the challenges of life, so that then we can be able to say everybody has some role to play. Those who can afford are paying for it, those who cannot afford are still able to get quality services, so that then again we can continue enhancing and driving and advancing the health of this continent. Because we know that this continent, once it's healthy, it is going to be the continent that the future will look up to. We are already seeing that, with many corporates and many of our, really highly skilled and talented individuals being taken up by foreign governments or foreign countries to do things that they should be doing here. And I think it's for us to build an environment that allows and encourages them to stay on board, to be able to build this continent, our countries within, to build, for the future that we see, that will be the future that we all want. And I think, again, just reminding us that we each have a role, wherever it is. It may be very small, but I think or big, or whatever it is, I think we really need to capture the moment and remember that the future is now. We cannot wait any other minute. Thank you very much, Marlos. Back to you.
Thank you very much, Dr. Katari. The time is now, duly noted. And I think we are all in the same boat, as we are all in this session talking about women's health, and in finding ways how to overcome some challenges that are there and how to solve certain situations. I want to move to the open forum. I'm receiving some questions as we speak. I've also noted some questions from our previous conversations. So I'd like to go to that. And my first question is for Dr. Matiko, to go back to our first speaker. Dr. Matiko, you there?
Yes, Marlos, I'm here. Sorry, I was on mute.
Great, no problem. I have one question from the chat, actually. It shared a story about women empowerment, and the question is, how can we empower women economically to enable them to afford health services and improve reproductive health, especially those who have lost formal employment and are running small businesses? What would be your answer in terms of, empowering women economically so that they're also able to offer pooled risk pooling apart from the SHA, for example, or even the SHA? Dr. Matiko, over to you.
I know, again, it's a more complex question because it revisits a little bit more around the macroeconomics of the country, because looking at women economic empowerment, I mean, it all goes back to how we structure our policies around not education. How do we make sure that women and especially girls have access to education? But even goes to the level around how about the labor laws? How do we make sure that there is gender equity and equality in terms of employment opportunities and all that? Then it goes to what sort of safety nets have we put in place, knowing clearly that to a certain extent, a number of women, and especially rural women, are vulnerable and needs to be sort of be put, access certain safety nets, not only safety nets from a government perspective, but even how the private sector shapes lending or access to loans and other investments is actually shaped to respond to women. And I know a number of foundation and philanthropic organizations have shaped interventions that are targeted to women to help to enable them have access to that. So that's a whole other perspective that we can think about. And so even as we talk about them affording to be part of the health insurance mechanisms, there's a whole mechanism around how we can put them in place. But that being said, even how we shape, and I know a number of countries, and I know Kenya previously had a whole fund around Linda Mama, which essentially meant women have access to free, let me call free in quotes, that a prepaid mechanism to enable women or pregnant women have access to ANC and safe delivery without having to pay at the point of care. So that sort of absolves or provides such kind of financial protection for them to enable them access that services. And so maybe thinking about, are there more services that women are looking at? If we're talking about cervical cancer screening and others, or family planning and other services, or thinking about how can we make sure that we, at the very least, financially protect them from having to spend money as and when they need the service, and they just access them because they need the service to be accessed. So those are some of the things that we can think about at a macro level, but again, have to imagine how do we shape the financing mechanisms to respond to some of the specific needs that women do have. Thank you.
Thank you very much. What you were saying also made me think, talking about safety nets in terms of financial protection. I'm also thinking safety nets in terms of awareness, like how, we are talking as healthcare professionals in our own bubbles in a way. We all know the value of healthcare financing, or health insurance. We know all the value of preventing, why it is important to vaccinate, to check, to screen early. But I think in Kenya, we have to say the common wananchi, like the average person has a big knowledge gap. They don't trust insurance, as was mentioned before. They don't see the value. It's wasting money because you don't see immediately your returns back, and you need to get something back. Otherwise, it's not worth it. In the same with vaccination, there's a lot of stigmatization in terms of vaccination. Even family planning has a lot of ethical or religious linkages to it as well. How can we make sure that these discussions we're having, or at least the awareness, the education is there with the people, the girls who go to school or the boys who go to school? Is this incorporated, for example, in Kenya, in the national curriculum, in high school, apart from abstinence and the workings of the biology of sexual reproductive health? Are, for example, young boys and girls being educated about the importance of vaccination, for example, for HPV? Or are children in school being taught about the importance of having a health insurance? Or what does risk pooling mean? What does the social health authority now mean? Is that education being provided right now? So moving away the healthcare discussion and that linked also to what Dr. Lucy said, health security is linked to national security. We should not talk about health security issues like preventive care, like risk pooling, in health care silos, because it's preaching amongst the choir, right? Are there active deliberations, for example, at the Kenyan level, being done to bring this to the regular discussions in terms of government policy and the likes, and to make sure that actually that political level that is not necessarily specialized on healthcare particular also sees the benefits of it and will prioritize it, so that the political elite will also move forward? And if that's being done, if yes, how, what works, what maybe doesn't work, where do you start? Like, where would we start, for example, in this case? I don't know, Dr. Matiko, if you have any experience or views on that. Love to hear.
Me too, and I know it's of course more complex, and maybe I think from my perspective there are two sides to it, based on the question. So one is, how do you influence health seeking behavior, and of course we're looking at a very big range of that in terms of awareness, and of course there are many other determinants around health seeking that probably is beyond what we can talk about today. Awareness is one, but again, the bigger challenge that we do have, sometimes we push a lot of blame to, let's say, to the patient. Let me call the patient, but it's just how is the health system prepared to address the needs of the patient? Because then, if the health system is not fit for purpose to actually deliver quality care that is responsive to the needs and culturally appropriate and all other measures that we're talking about, then it's a whole complexity. Then we have to will remain blaming the patient. Why are they not aware? Why are they not getting the call? Why are they? So it's basically how we shape the health system to respond to the needs of the patients, instead of having to continuously blame them. Why are they coming? But also we have to change. Why are we not taking to them at their convenience? And then, of course, not underestimating the physical barriers. There are other macro issues around access to education, basic education, income, and other things also come into play. And so that's more complex, and happy to hear from my fellow panelists. The second part to that is around education, just around health financing and more so insurance mechanisms. So it's a very complex topic, especially in a culture that sort of believes that by the time you're paying for, in case you get sick, then you're potentially asking that you get sick. So the whole element around insurance is probably something that we've not done well in explaining what that means. And a lot of private insurers will tell you, especially in our setting, a lot of people see the money, the premiums paid as their money that they need to exhaust, instead of having to look at it as a solidarity sort of approach, that we're putting together money in case one of us gets sick, then uses the funds, but not necessarily that all of us should go in and use that fund. And so that's sort of all that I'm a young 25-year-old, probably zero risk, that there is need as part of social solidarity, or in case of just risk, then we need to get into that. So there's a whole education that we need to do, but I don't think we've not done that well. And especially as we said, national health insurance systems, to be interesting to see how then do the national health insurance system contribute to that. But even what is the role of association of insurers, or what is the role of regulators in terms of how they embed some of this into the education system, or how they roll out, so the understanding that people do have around insurance in itself. So those two sides, there is a care seeking in terms of how much we can do, but also the part around insurance, the much that we can do. There's quite a bit that we can do, but happy to hear what the panelists are thinking about, especially as we think about, funding cuts, then what we'd have to step back and think about how we do it ourselves. Thank you.
Thank you very much, Dr. Matiko. I think that's very, very clear. I think what I also get away from is, can you know what you're looking for at a patient or individual level if you don't know that it exists or how it works, and I'm not sure if that's only the health sector to inform. I think it's a wider, maybe educational point of view to look at information sharing, so that we don't operate in silence. I see you, Vuyo, there. I have a question for you. So it's good I see you with your camera on. Where did I write it? I had it here. Yes. You mentioned social solidarity in your presentation. And one question that we got from the crowd is, how do you translate the principle of social solidarity at the point of care, especially regarding sexual and reproductive health and rights? So, Vuyo, over to you, translating social solidarity to point of care.
All right. So, I try to think about these things quite simplistically. We have access programs that we run across the world for one of our key products in the oncology space. And the way in which we've done it in some markets where the legislation allows, is we have 5 prices for the same product in the same country. And so when a patient goes to the doctor and they have clinical eligibility based on the product label, the doctor would then refer them to an organization, an independent third party, who would conduct a financial means test. Based on your level of affordability, you pay a particular price. And it goes like that up the ranks. And so if, for example, we had a situation, and I think it even happens in South Africa, anybody can go to a public hospital, but it doesn't mean that because you're going to a public hospital, you're not going to pay. And so if, for example, when they assess you and you have to provide your proof of income and your salary band is fairly high, there will be an amount that you are charged, even in a public institution. And so, and what happens is that when you place those resources all together, you are naturally subsidizing those who don't have. If I pay, even at a public facility, or if I pay to government for a product that they've negotiated a price on, it means that I'm not paying as much as an individual. If I was alone on by myself, and I'm diagnosed with breast cancer and they tell me I need this particular product, and then I go and source it, maybe I have to fly even to another country to get it, or do all sorts of things on my own. By virtue of government negotiating a price nationally for it, it is going to be lower. And that means that as a person who can afford, who's comfortable paying for their own health services, I'm not paying so much that it becomes toxic or catastrophic for my family. But what I'm doing when I pay, it means that somebody who has less than me can go to the same facility and get it for a lot less or for free. So I think that's really what I meant when I talked about payment at point of care. It wouldn't necessarily be for everyone. It's based on your affordability and your ability to actually pay. I think one of the things I heard once, I was in Ghana and we had a meeting with the Breast Society of Ghana. And many of the oncologists even said, I don't know why they insist that we all pay a flat rate for the national health insurance. Why can't I pay more? I can. And if I pay more, it means that there'll be more resources in the pot to service those who can't. Right now, they're just saying, we just don't have money. But why? Why? If you can pay more, why can't you pay more? It's the same principle we do with tax. Your tax bracket is higher based on your income level. And that tax money goes into public funds that provide public goods, improve roads for everyone, build schools for those who cannot afford private schools. I think we need to adopt the same mentality when it comes to health.
Thank you very much. Are you still there? Yeah, okay, great.
I am. But one more point I will make is I think all of this is only enabled when you have a very strong data system and you're able to, you have personal identification numbers and you're able to track everybody in the economy, identify where resources are being wasted so that you can reallocate accordingly. And so I think all of these things are really underpinned by strong data systems.
I think that is also key. I think, for example, in the Kenyan situation where the formal employed people do pay per means or pay a percentage of what they earn. So if you make more, your percentage is a lot higher. Actually, I think the principle of it is okay, but then you need to make really sure that the back office also works, so to say, so that the quality of care is actually provided, and that's not only the highest payer, but also the ones that contribute a little bit get the services that they are paying for. And if you put money in a leaking bucket, it continues to leak. And I think that is where the resistance is coming from in terms of the people with a higher income willingness to pay. So how do we ensure that governments fix those leaking buckets first before asking for more money? How can you hold governments accountable? You cannot put money in a bucket that's already leaking. Well, sometimes we're doing it already. and not be accountable for it for the people, you know, who receive it. And I think that is a bit of the resistance that you get even from companies, like how Qatari was mentioning, you know, more input from private sector. I think private sector is contributing a lot when you talk about VAT, withholding tax, all the taxes that are being paid, the income tax, everything, PAYE, that should all be in a kitty that is used well. And I don't see a reason why private sector wouldn't want to pay more if they see the benefits of it, but paying more in buckets, I think that is the challenge that a lot of, you know, that is happening in a lot of African countries. So how can we create better transparency systems? And even if it's transparently leaking, how can we fix those leakages and hold institutions or maybe even individuals really accountable to stop that leaking? I think unless you do that, the leaking will continue. It becomes smaller drops, but it's still not efficient use of money. So pooling funds is a great thing, but pooling funds in a leaking bucket is still waste. So how to stop that?
So I think here we have to exercise a level of realism and pragmatism. You know, we could talk about the long route of how we generally hold governments accountable in our democratic nations. But that, in my view, can be a long and tedious thing and something that is often without guarantees, as you rightfully say. So for me, I think the practical solution is really the importance of public-private partnerships. You know, UHC, that also doesn't have to mean that it is the national health insurance. I think that you can have managed healthcare organizations or administrators that are contracted to government and can actually run a proper health insurance fund. And similarly, UHC doesn't mean it has to be public institutions that are providing healthcare services. And so one should be able, with a good or comprehensive health cover, to be able to go to a private primary healthcare facility or a private hospital. And I know that when we talk about these things, and I hope Lucy doesn't kill me, it's almost like we are saying private is better than public. That's certainly not what I'm saying. And I think there are many examples across the world where public is so good that many consumers would rather go there. And a good example is Turkey. In Turkey, they have universal health coverage, and many patients would opt to go to a public hospital. But that's because it's well run. It's also because that hospital isn't necessarily wholly owned by the government. And I think the biggest challenge with government ownership is actually just about the ability to hold people accountable. And I think it's something that we struggle with in our markets and in our countries, where the quality of leadership and the quality of governance, even when it's there, the systems are not there to support leaders to have decisive action, to hold employees accountable. You know, I don't know about many other African countries. In South Africa, we have a very strong labor union movement to hold somebody accountable in the public sector. It's a whole job on its own. And so I can just imagine somebody who's well-intended joining and leading a hospital, one of the biggest hospitals, with a great vision of turning things around. And the minute you start to drive this change, you get all this resistance. When you try to hold people accountable, you have unions on your back. I mean, there's just a lot to be said about the systems around public, which make it difficult to hold people accountable. And I honestly think that in the shorter term, the solution has to be that care can and should be provided in the private sector. And some of these activities and actions need to be outsourced by the government, so that people can build greater trust in their health system, and in doing so, perhaps be more incentivized to save and to contribute, like you said, Malus.
Great, thank you. Yeah, I've once I heard patients, people choose with their feet, and in the private sector, those with the money, who have money, they will choose where they will spend their money. So automatically that will be the assumption that that's the provider that offers the best quality of care, value for money. But unfortunately, those who don't have that money cannot choose, and they should get that same quality of care. And ensuring that is, I think, as you said, also a collaboration of public-private partnership and collaboration together. And that is also a nice bridge to Dr. Lucy. I hope you're also still there. You mentioned in your presentation or in your speech that Africa CDC is integrating women's health into UHC, both in the private and public sector. How practically have you integrated women's health in the UHC discussions that you are, positioning at Africa CDC level?
First things first, remember that health is the responsibility of the member state. And as the Africa CDC, our role really is to provide an advisory space to the member states on how best to improve their situations. And so we have experts who develop, for instance, frameworks, and then these frameworks are then shared with our member states, and they are helped to adapt them to the country context. So we have quite a number of platforms where we engage with the decision makers, but also the technical space. So we start with the technical teams so that they understand these frameworks, they understand these strategies, and embrace them. Then once you have the technical group understand that, then you can move it now to policy level. We have different governance structures. We're able to bring together heads of states and government and have discussions around that. But prior to that, we should have been speaking to their ministers of health, to accept that this is a correct policy direction. And prior to speaking to the ministers would have been speaking to the technical people. So there are all these stages that you need to pass through before you get to the high level policy decision making. And we do a lot of analytics and showcasing best practices. You have good examples. So, for example, recently, I think at the beginning of the year, we had the president of Rwanda speak to his colleagues about the issues affecting the nations, and how best to move, using their best practices as an example. We heard just right now about how the private space seems to offer better facilities than the public spaces, but in some countries it's not so much like that. You find that because of social health insurance, for instance, they've been able to improve the facilities even in the public sector. So countries like Rwanda, for instance, in their social health insurance system, everybody, irrespective of how much money you have, will pay equitably a contribution to the social health insurance. Then they have innovative ways. So, for example, monies that are pulled out of things like people are charged for traffic offenses or other things. That money is pulled and it is used to pay for those who have been recognized as definitely are not able to pay their own social health insurance. And in that regard, the whole country begins to feel comfortable, because especially in the spaces of increased disease burden, you begin to recognize that if I don't have an input and that person is affected, it will affect all of us in a way or another. And so engagement with the population also remains key. And I think the increased utilization of primary health care to move this agenda remains key and critical. But what we also see is that ministries of health are important, but they can't work alone. So when it comes to issues of financing, you have to get the people who are holding the purse to be on the table. And so the Africa CDC has been in the platforms, has also been bringing in other important entities like the Ministries of Finance who who understand more and act when we, push the agenda on reframing women's health as a development and economic issue. Because when you're looking at health just as the absence or presence of disease, the context is different. But when you're talking to the Ministry of Finance, you look at them this as, look, this women's health has a connotation to development and to economic issues. And there's evidence, we've generated evidence. We've seen that, investing, for instance, in social reproductive health and maternal health, it has saved many lives and it has boosted productivity. So that's the data that you bring into those spaces to get the interest of the people holding the purse to say, I think now we agree that we need to increase the fiscal space for health. And in this particular situation, women's health. And, there are also some interesting tools that have been shared with the member states to understand this context, such as costed investment cases and the different fiscal space analysis that help these guys understand the return on investment when they put money on the health sector. So as Africa CDC, we've been doing a lot of high-level advocacy, facilitating dialogue between the Ministries of Health and Finance and other important entities, the private sector, the regional economic communities, towards championing health financing, and leveraging on existing platforms. So we have a lot of summits, we have a lot of meetings, and so on and so forth. And so we use those spaces to push that agenda. We also encourage a lot of engagements with the parliamentarians who are key in moving the law and giving them the context, and so that when the policymakers bring in the request to push in a law, they are already engaged, they understand, and they embrace it. And then we also have some leadership forums for our leaders, both at policy and technical level. Leadership meetings, leadership trainings on investing in health. At the WHO, on the sidelines of the WHO, we had serious conversations with our ministers of health on how to move and improve, dedication, or rather dedicated allocations of financing, looking at what are the big issues. So women's health, maternal health, those are big issues that are affecting our health space, and also the security, the national security in its entirety, but also the economic spaces and so on and so forth. And so there's been a push there, and we continue to push. We now have a dedicated primary health directorate, which is looking at all these issues of sexual reproductive health, maternal health, adolescent health, and how do we push member states into embracing a change and having dedicated financing into these spaces. And so, I think that there are a lot of innovations that are being looked at by member states, but we have played a very big role in advocacy and having those discussions and bringing together the important people in the room to make those decisions.
Yeah.
Thank you very much.
Thank you very much. And I've noticed, and it's very good also for you to get a stepwise approach how you do it. And just to imagine, you do it with more than 50 countries. It's a lot of work, and you know, you're being responsible for the East African region. It's also a multitude of countries that you need to focus on, and different national systems, not only the ministers of health, as you mentioned, the minister of finances, even parliamentarians. So yeah, hats off to you in the advisory role that you're playing, and thank you very much for being with us and shedding a bit light of also how that side of the coin works in a way. I'm just very cognizant of time, but I want to give Dr. Gattari one more question before we go. One question I got from the crowd is, people have said private sector financing can help. But what does that mean practically if we talk about private financing? Just keep it a bit brief. I'm sorry to cut you short. I really don't like it, but I'm just cognizant of time.
Thank you. I think really that refers to, there are various levels, of course, and many layers to that. It could be like, you know, a citizen themselves funding, you know, using their out-of-pocket cost to use private sector facilities. But I also think the other element is that on this continent, we are not short of, you know, high wealth net individuals. But I think it's, are we talking to them? Are we reaching out to them? And I think perhaps also going back to the earlier conversation around the leaking bucket is I mean, how do we change the narrative so that we are not every year, every, for example, every electoral cycle, we are placing back the same guys who are going to run with these buckets, and so we really do not bolster you know, public confidence in our public systems. And I think that that's one thing. So perhaps even us as citizens and as part of the electoral process is to make sure that we look for people with track record. If your record is bad, I don't see why we should get you back there. But I think too is that what are the incentives for me? What is it in it for me if I'm contributing this to subsidize somebody else? There must be something else that maybe I should get sort of out of that. So for example, if I'm an entity in the corporate sector and I'm contributing to the welfare of the community that I live in, does the public then recognize that and give me something else in return? And it could be just perhaps opportunity for us to advance my business, but also again, perhaps maybe some subsidies on others, like there's improved efficiencies in the way I'm doing businesses. Again, I know that this is not something that we can sort of crack or rather one size fits all. I think to look for solutions that are very context specific. For example, in one of the counties around in Kenya, you know, we're having conversation and asking them. So we have people who are interested in investing here in this kind of industry. As a minimum, can you tell them, if you are going to get this entity, whatever it is, you know, we can give you land free of charge, but we also ask that you give us something else in return beyond the business interface. There should also be something that you're giving back to society. And it could be in terms of health, improving, it could be preventative service, it could be making sure that water and sanitation is also improved, whatever it is that looks like. But I think also the other bit is to ask ourselves that if I'm coming with some health programming, that I also, you know, our governments, and I think ministers of health, perhaps being the custodian of health, that they also do require us to say, if this is what you want, this is the minimum you need to do. For you to be able to get this, there are some conditions that you must meet. For example, if you're talking about something very well big in terms of high-end equipment that you want to set in, but think about the whole value chain. You know, what is it? How is the user journey? Are we able to invest a little bit also in primary healthcare so that they also benefit from that? That it's not just limited to that high-end opportunity, but looking across the ecosystem, what it is that we need. And I think, again, like I said, these are things we need to be looking for and discussing in our own ecosystems or in our own environments, but also engaging other sectors. I think for long we've talked about making sure that, and we know very well that health is not just a matter of health, it's the whole socio-economic environment. There's so many other things, and I think we need to be reaching out to these other sectors as you're having this conversation. Thank you very much, Manos.
Thank you very much, Dr. Katari. Can I take that also as your parting shots as I'm winding up towards the end of the session?
Absolutely. Just to,
I think it was perfect.
The time is now. Thank you.
Yes, definitely. Let me then allow me to work backwards. I would like to bring Dr. Lucy back for maximum 1 minute, maybe 30 seconds, a parting shot at your key reflections on this session, if you have, please.
Thank you very much. A very well articulated webinar. I think for me, in closing, I really want to just emphasize that women's health cannot remain donor dependent. We need to institutionalize domestically owned and regionally supported financing, and to recognize that governments cannot meet the growing needs of health financing, and therefore there is need to promote that public-private partnership, to mobilize private capital, to invest in local manufacturing, in labs, digital infrastructure, and so on and so forth. And lastly, to just indicate that as the Africa CDC, we remain resolute to supporting the member states in building resilient, gender-responsive, and sustainable financing systems. Thank you very much.
Great. Thank you very much, Dr. Lucy. And I know you're part of the ongoing discussions. Even in Nigeria, you're going to be with us. I think your team will also be. So looking forward to continuing collaborating with Africa CDC on this, also recognizing the stewardship and the guidance role you give to the ministries of health at the national level. So thank you very much. Vuyo, over to you, parting shot.
Thank you. I have also really thoroughly enjoyed the session and listening to my fellow panelists. There's one thing someone said once, which I have always loved. Ministers of health are not just ministers of public health. Ministers of health are ministers of all health. So my parting shot is just to have an integrated view of health and think through how private and public can work together to improve health outcomes. Thanks.
Thank you very much. Last but not least, Dr. Matiku, parting shot from your end.
Yeah, I think and it's been a sort of a recurring theme, two things, especially as we talk about, addressing women's health more so under the funding cuts, is efficiency, integration. But the thing is, with the participants and even the panelists, is just how we break down these two terms to actionable items to advance what we're talking about. So the two, if we can work with the two things, break them down to actionable items, support governments to actually actualize them, and then that would be a good starting point for us. Thank you.
Great. Thank you very much. Left me nothing to be but to thank you all for your participation. Thank you for our esteemed speakers. I've learned a lot. I thought it was very engaging, and I think we are all aligned in the thinking that we are having. So if we can be aligned, I think everybody can be. So I agree very much with Dr. Matiko. Let's move this now from talk to action. And what you can expect from us is also a comprehensive session report with key action items that we as a coalition will also pick up as we are moving forward. As moderator, I want to say thank you, but please stay on. I still have Natasha online to give you some final notes or words of wisdom. But thank you, everybody, and looking forward to other engagement. And don't hesitate to reach out to us as the Secretariat in case you want to know more about COA or want to come on board or see how we can collaborate together to advance women's health. Thank you very much. Over to you, Natasha.
Thank you, Marlos. I just want to take this opportunity to thank our esteemed panelists, our wonderful moderator, Marlos, for navigating through this powerful conversation. It was nice to see a spectrum of different opinions, views, and the different work that's happening in all these sectors. And I think your voices actually remind us that the fight for women is not just women's health, is not just urgent, but it's actually very personal. So on behalf of the coalition, I'd like to thank you all. Let's keep this momentum going and continue building a future where all the women in Africa, their health is prioritized, is protected and funded. Just before we drop off, I'd just like to mention COA will be hosting an exclusive roundtable in Nigeria on the 17th of July, again, building on this webinar. The conversation is going to carry on, but this will be an in-person roundtable session. It will be focusing on bridging the gap domestic investment for women's sexual reproductive health amidst global funding shifts. So yeah, to our members and strategic partners, the invitation is open. So if you'd like to join our coalition, please reach out to us. The next slide will have our email, our website. So please feel free. We have some of our reports that are currently available on our website, so please feel free to review them. And thank you once again for your time, and have a wonderful day ahead. Thank you.
Thank you.
Thank you, everyone. Bye.
Everybody, have a good day or
Bye.
afternoon, wherever you are.
Bye.
Thank you.